Okay, so thank you both for coming today. Let's start with a bit of background on both of you. So, Benjamyn, perhaps you could tell us a bit about NHS Shared Business Services for the uninitiated.
Well, good morning, everybody. NHS Shared Business Services is an organisation that many people in the health industry will have heard of and come across, because in many cases we're the people that actually get you paid in a straightforward, practical sense, and that may be through payroll, it may be through procurement activity, or it may be through any other aspect of finance and accounting. We, as an organisation, amongst other things, process all the receipts and payments through the entire commissioning network, so clinical commissioning groups, NHS England, and everybody in between. If you are sending invoices to commissioners, in practical terms, you send your invoices to us, we do the processing, we get you paid, we manage the bank accounts, and we do the finance and accounting for the NHS organisation behind that. We have a similar operation through payroll and HR services. We have procurement activity that ranges from help with strategic procurement, actual procurement activity and contracting, through transactional procurement. And we do all of those sorts of things.
Okay, and Cloudbuy?
We do a range of things covering off procurement, where we do analytics to find out the different prices that all the items are being paid for and to help organisations to buy better. And then the other area that we're collaborating with NHS SBS is round about social care, where the NHS is now moving into personal budgets, and the local authorities have been doing that for a number of years. And so we've got quite a lot of experience of how to deliver that for large numbers of people within the local authority space.
Okay, so we've heard already this morning quite a lot of targets being talked about, and objectives and goalposts and dates when we want to do things. So let's throw another one into the mix here. So by 2018, the intention is that 5 million people should have combined health and social care personal budgets. Give us the background to that. What's the driver behind this? What's the context here? Benjamyn?
Well, there's the side from the local authority side of things is this joint working between health and local authorities, because very often the same person is getting a budget from both the local authority and the NHS. And one of the things about having a system that works across both is it makes it much easier to combine that budget, so the person can then make an informed decision about how to spend their budget. And one of the things we found with the local authority space is that when the person actually gets given a budget, they're in control of their life again, because they've gone through all their life in control, and then suddenly they become dependent in their late years. And if they stay in control of the money and having choice on where to spend it, that actually results in better outcomes for people. And that's one of the drivers behind personal budgets. And
I think I would take that a stage further and say that governments over very many years, and I don't just mean the current government, but previous governments as well, have emphasised patient and individual choice in society and community. And I think for too long, we've seen the model of patient as victim. And if I think of my mother in her mid-80s, who is in generally good health but has some issues, she's a typical lady, the Giles cartoon with a walking stick and strong views. She would see herself as a victim of the health service. The doctor tells her what to do and when to do it and how to do it. And the idea that she might contribute to that, saying, actually, I'd rather do it some other way, whether it's that she doesn't have the confidence or doesn't feel empowered. I think what personal health budgets are aiming to do is to put the patient back in control. Now, patients may not know how to do that. I don't know if any of you have bought a new car recently, but you go into the showroom and you say, that's the model I want, but then you have to decide whether you want the leather seats with the climate control or you want the fabric seats with the sunroof, but you can't have all three. How do you make those decisions? You don't know how to. I think there will be a major exercise in helping patients to make choices to enable them to help themselves. And one of the things we're working towards is technical solutions, models using the internet, using web browsers to enable patients to help to make the choices that best help themselves.
So, Ronald, what's your sort of experience to date from local authorities on this front?
It's been very positive. There's a lot of work that's been done in the sort of pilots in local authorities. Local authorities have been doing it for quite a long time, and they found, from their point of view, they cared about saving money, and they save significant amounts of money by actually giving the person responsibility of the money, because they care about it in a much more personal manner than the local authority did, and were actually more innovative in the way they spent it as well. The other, some of the challenges that came out of that was some authorities then went off and put in a lot of admin on top of it, which took up the savings. And so we've been working with authorities to make it easy for somebody to basically choose their care and then automate all the admin around about it, so they don't have to account for it and report back on how they spent every penny. So they get the budgeting and the admin automated, but they remain in control of how they choose care. And those are very important lessons to bring back into the NHS when it's going through the same process.
And there must be particular challenges facing the clinical commissioning groups as a result of this?
CCGs have, a number of challenges. Firstly, in all cases, they're relatively new and immature organisations. And organisations at this phase of their development, they've only existed since April 13, organisations at this stage tend to put in more control, more risk aversion, more management of that. And that means the temptation to try and micromanage everything down to patient level is there. One of the things we're looking to do is put in solutions that provide the management information that says, do you know what, as a clinical commissioning group, you don't need to worry about the micro detail. Yes, you need to worry about the patient holistically, but how they spend their personal health budget is a matter for them, and as long as the right controls are in place to make sure they're not spending it on booze and fags, but are spending it on which make them feel better, there's no argument about that, but they're spending it on what they're meant to be spending it on, the clinical commissioning group can have confidence that the patient is only able to do the right things within the scheme of things, and at the same time do what is best for them individually, because they are the best judge of that. I think that's one part of it. The other part of it is, if the clinical commissioning group is responsible for providing all aspects of health and equipment and support, when the ferrule comes off the bottom of the walking stick that costs kind of 50p to replace when you go into Timpson's, if the CCG is trying to buy a ferrule and get it to the individual, I can't tell you what it's going to cost, but I'll bet it's more than 50p.
Yeah, it goes back to e-procurement days of paying 80 quid for an 80p packet of paper clips by the time you've gone through the process. Ronald, how do we manage the quality in all this, though? Because it's obviously it's an opportunity from the supply side to get into this space. How do we make sure that you're going to get quality service, quality offerings?
One of the things we've learned for local authorities is something like TripAdvisor, where we actually have star ratings for all the providers. One of the challenges the local authorities had, and it's the typical same sort of bureaucracy as the NHS, none of the local authorities could agree on whether to have comments or not. One of the great things about the NHS and NHS Choices is there is a monitoring system so we can use, so we can make sure there's comments up there, because people actually want to see comments on what a provider was like, etc., etc. So it's actually passing that control down to the patients and getting that feedback and using them. And as we heard earlier, there are a lot of comments coming in, and using that process does give you a much better feedback than the old method of an annual contractual review of a provider.
That kind of TripAdvisor thing, though, I mean, we're here talking about cloud today, and one of the things that people have asked for most for the digital marketplace, or the cloud store as it was some kind of TripAdvisor type thing, and there's a great deal of resistance from the Cabinet Office on that because they think it's open to abuse. Is the same not the case here?
Well, we've been running marketplaces for 15 years, and that star rating has been one of those features that's been an early thing, and it's been proven in all the other our marketplaces. It's something you want. You look at a provider and you want to see what's the quality of service, what other people have fed back, and one of my points in the cloud store is there are other systems that already deliver it, and you could go into cloud store and buy stuff and pay for it by card and have it all delivered if they just let us.
Okay.
If I might add to that, I mean, those of you that use TripAdvisor or similar to, other rating systems are available. If you use TripAdvisor, what you see is here's an organisation that's got 147 very good and outstanding and 2 terribles. People do have bad experiences, and you note that. But you look at the thing holistically, and you say if somebody's got 147 good ones and only 2 terribles, they're probably an okay organisation. I think we mustn't underestimate. There may be patients with difficulties, be they physical difficulties or mental difficulties, but actually most people know how to organise their lives.
Okay, does anybody have any questions from the floor? Okay, hold on one second.
Hello, Mark Smith, Head of IT and Operational Systems at Monitor, and also Chair of BCS Health Specialist Group in London. I've worked in health for most of my life, and I keep hearing choice, choice, choice. And having worked in the East End of London and living in a rural part of Essex and nearly on the Suffolk border, I'm always concerned that if you're in somewhere like Norfolk, you haven't got an awful lot of choice if you've got acute services. And if you're a non-English speaking person with a very low wage in Hackney or somewhere around there, your choice is which hospital or which place can I walk to? How do we address that inequality? Because actually, for the educated middle class people like most of us are, that's fine, we can have choice. But for a large proportion of the world, that doesn't exist, or it's very limited. How do we overcome that? And TripAdvisor doesn't help.
Indeed, and I take that point, and I live in rural Lincolnshire, and what choice do I have of facilities available in a whole variety of ways? I don't think there is a technological solution that is going to be able to answer that for everybody. If you live in rural Norfolk, or you have to go within walking distance of where you live in Hackney, I don't think there is a technology solution that is going to answer it all. But I don't think that's justification for not increasing the opportunities of choice for those that can access those services. You know, there are things, as you say, if you live in rural Norfolk, in practical terms, there are choices and services that you're just not going to be able to get to. But that shouldn't necessarily deprive you, living in rural Norfolk, of the things you can do because you can order them online and get them delivered. You can arrange your care online in rural Norfolk and let the provider worry about how they get to you and how they find you, rather than you have to worry about how you find them and get to them. It's not going to be a panacea, it's not a miracle answer, but it can go a long way.
Ronald?
There's quite a lot of work we've done with local authorities in that area, because we're working with 3 county councils, and they usually have both towns and the rural area, and providing care in a rural area is always very difficult. We talked earlier on about saving money. We had a county council that saved £500,000 a year in its taxi fares by actually putting every journey out to all the taxi companies, so they could start planning their journeys and going, okay, I'm going out to there, then I go to there, then I go to there. Suddenly I've managed to make it into 3 trips rather than empty legs. So there's quite a lot of stuff you can do by actually putting that stuff online and making it available to everybody so they can collaborate. The other thing we do with county councils is the challenge of how do you keep your providers profitable? So you actually need to try and make sure your care providers in the rural area are profitable, because you don't want to lose them because there aren't enough of them, and so it's making it as easy as possible for them to get business. We build websites for them so that you can find out that there's a provider locally to you, and it's trying to make it easy for both the provider to do business in the area and the people to find the providers that do that business. Because if you have to go back and get care from the nearest large town, it's obviously going to have to drive quite a long way to you, and there may well be somebody in your village that actually wants to provide care. And so there's a lot of stuff we're doing around that side of thing. That same challenge of basically logistics and transport, etc., applies to people that are walking around in Hackney. There will be somebody in their street that's wanting to do something, but it's how you get the 2 people joined up together, and that's where we're in the midst of that transition from all the information being quite difficult and inaccessible to trying to make it accessible and easily accessed locally.
Any other questions? Okay, well, perhaps I'll just close with one last question to both of you, which is, given the targets, given the 5 million objective, given the deadline, are we going to be able to do this in time?
Well, we think so. Cloudbuy has developed marketplace. It's there in practice. SBS has, NHS Shared Business Services has the systems in place to be able to facilitate the operation of that behind the scenes. We also, acknowledging the confidentiality questions that came earlier, we are very highly rated on the NHS IGAF assessments. We are used to dealing with all the confidentiality that goes behind this. This proposes us some additional but not new challenges, and I'm confident we can do this.
I think it's great. Something about confidentiality is called GAF to start with.
Yeah, it is classic. I think it's one of these few occasions where actually the technology is ahead of the game, in that we've been working with SBS for about 5 years on different things. We know how to do our joint working. We've got the solution in place for local authorities, so that's all in place. It's much more of a people and processes challenge, because there's 225 clinical commissioning groups, how you then deal with it. You've then got thousands of people to communicate in each area, and all that sort of side of things. So I don't think it's going to be so much of a technical challenge, but it's definitely going to be a people, process and communication challenge.
Okay, well, with that, thank you very much indeed to Ronald and to Benjamyn. Please give them a round of applause.